Ladies and gentlemen, good afternoon. Thank you for agreeing to take your time and go through with me the cytology of the head and neck. I've been lead for cytopathology at Imperial College for almost 20 years. And as you heard, I have some experience with digital cytology, which is slightly more complicated than digital histology because of the intrinsic issues with cytological material, of course. And however, we managed to scan these 4 cases, which we're going to discuss today. They are intriguing cases, so I would encourage you to go on the link and spend some time going through them. You feel free to ask any question on the chat line. Any question will be conveyed to me at later during the presentation. So we'll start with the first case, which is a 90-year-old female with a 3-month history of localized neck mass, which was enhanced and solid on ultrasound. It was in the parotid area. The FNA was performed, and what you can see here, the cellular slide was an air-dried slide, which was, of course, stained with Megrum-Gimsa. And as you can see, it was very, very cellular with clusters of these dark basaloid type of cells with dots of metachromatic material, which was globular, not particularly fibrillary, and with well defined at low power. The high power showed that the cells were remarkably homogeneous and monomorphic, with relatively little cytoplasm, hardly visible, and arranged around or on top this metachromatic material, which was very well defined. It wasn't really merging with the background, and the cells did not have a spindle appearance, but were relatively epithelioid. So what's the rational indication for salivary gland FNA? It's widely used at many institutions for the evaluation of salivary gland lesions. At Imperial, we had quite a few. We also have a few, but fewer, not as many here at NRL. It's safe, cost-effective, and accurate. And it's a guide for the clinician in assessing the need for surgical or other clinical interventions. Especially, it allows the surgeon to plan his intervention, because if it's a suspicious or malignant lesion, of course, there must not be any delay in the intervention. It's fairly accurate, and we'll go over the literature. Sensitivity and specificity for neoplasia is around 90%, and of course is lower, the accuracy for rendering a specific diagnosis. However, the specificity is very high in any case. We advocate the use of both air-dried as well as alcohol-fixed slides, because 2 different stains are used. The Romanowski type of stains for the air-dried, and those are Diffquick, Gimsa, or MGG stains, and the Papa Nicolau for the alcohol-fixed. And they show different things. You know, the air-dried Romanowski stained are very good for matrix components, so collagen, basal membrane, mucin, etc. And it's invaluable. It's really a pattern recognition in pleomorphic adenoma, which is the most common lesion, as you know. Instead, Papa Nicolau is very good and particularly useful for evaluating nuclear features and cytoplasmic differentiation. So our suggestion is to do 1 slide air dry, 1 slide fixed in alcohol for each pass, and then put everything else in a liquid vial. If we go over the most recent literature, I mean, meta-analyses do suggest that the number of inadequacy cases tends to decrease if there is on-site evaluation by a cytopathologist. And from 93%, you go down to 6%. And when a cytotechnologist is available, the rate can be slightly higher, but of course, again, that depends an awful lot on the experience of the cytotechnologists. Our cytotechnologists are pretty experienced, and therefore the rate is not any different from when the pathologist is attending. When it's not possible, of course, the best thing is to relate with the cytopathologist and the lab in order to agree which is the best way to process the material and to send it over. You will be asked by some of the clinicians, I'm still asked anyway, whether there is the danger of tumor seeding after fine needle aspiration. And again, this is another meta-analysis, it's pretty recent, and as you can see, is exceedingly rare. So it's like 1 in almost 100,000 cases, or 10,000 cases, sorry. And it depends a lot on the diameter of the needle. If you tend to use 25 and 27 gauge needles, of course, the danger is absolutely negligible. If it's sort of a large needle core type, of course, there's a slightly higher danger, but still, it doesn't justify not to use FNA. So what are the normal salivary gland aspirate features? Well, we see exactly what we see in histology, that is serous or mucinous acinar cells in gray black clusters with background naked nuclei, because the cytoplasm is very fragile in acinar cells, and then admixed small tubules and sheets of ductal epithelium with eventually adipose tissue. And this is a high power view of one such FNA, and you can see here on the left-hand side the ductal cells, which are columnar cuboidal, and on the right-hand side you see a nice acinus made of acinar cells. And the cytoplasm is vacuolated, almost foamy, the nuclei are round, eventually they might have a small nucleolus. But the cytoplasm is very fragile, which is why bare nuclei are commonly present in the background. And this is the equivalent histological image, and you can see very nicely the ductules and the background of the serous component of the acini, of the glands. So which is the classification most commonly used? I have to say, because of my age, this is not the first classification I've been using. I hope it won't be the last one, it might though. But anyway, every classification needs to be explained and has its gray areas, and there's nothing replacing a good description of what you see on the slides, together with a final diagnosis suggesting possibly the differential. So we have 6 categories: non-diagnostic, non-neoplastic, benign, atypia of undetermined significance, which is AUS, neoplastic, which can be benign, such as in pleomorphic adenoma, or uncertain malignant potential when we don't know exactly where we are standing. Then there are the last 2 categories, which are associated with a high risk of malignancy. In fact, if you check the risk of malignancy with each category, you will see that while it is extremely low in non-neoplastic, and this is the 10% is simply due to sampling errors in the vast majority of cases, because the lesion can be small or can be very scantily cellular, non-diagnostic, and then atypia of significance of undetermined significance. It ranges between 10 and 35 in the different labs, and it gets very high with suspicious malignancy and almost in the 90s for malignant. So again, there is a gray area. The gray area are predominantly the atypia of undetermined significance and the SUMP, the neoplasms of undetermined malignancy. These can be difficult to reproduce, but there are recommendations. For example, in the AUS, the authors of the Milan classification recommend to use it rarely, no more than 10% of all salivary gland FNAs. It cannot entirely exclude a neoplasm. It's quite heterogeneous, and most of them will show just reactive atypia, and it's usually a poorly sampled neoplasm or poorly preserved as well. It is the AUS lesions are usually low cellular or technically compromised, and they can be cystic. In all cystic lesions, very often we have less material and more background to confounders. So it is pretty much a indeterminate entity. The neoplasm of undetermined malignant potential are usually cellular basaloid neoplasms. And you might recall the ones we've seen today, case number 1 was pretty basaloid. It wasn't oncocytoid, and it didn't have granular vacuolated or clear cells as well. The metachromatic material which you've seen in the first 2 images of the case might resemble superficially the material which is so common in pleomorphic adenoma or mixed tumor of the salivary gland, in which this metachromatic material is, however, very fibrillary and not well defined, while instead the cells are both either plasmacytoid or spindle, and they usually have more cytoplasm than in either basaloid lesions or adenoid cystic tumors. Chondromyxoid matrix is not as well visible in Papa Nicolau. You can see here a nice example. On the left, you can see the spindle nuclei, myoepithelial nuclei in the background, and the myoepithelial cells more of a plasmacytoid appearance on the right-hand side. So this would be a fairly typical appearance of pleomorphic adenoma, and it's sufficient to separate pleomorphic adenoma from the other lesions. There are pitfalls, however, in pleomorphic adenomas. Sometimes you can have very cellular lesions with sparse or actually absent matrix material, or on the other side, you can have only chondroid matrix type of material and hardly any cell resembling the typical cells of pleomorphic adenoma. Then you can have areas with focal adenoid cystic areas, like areas, lesions with cytologic atypia, or metaplastic changes such as squamous or mucinous features. These are the main pitfalls of the lesion. This is the histology of 2 such examples. On the left, you see a very chondromyxoid-rich lesion with very little cellularity, and in some cases, you might have just a chondromatous type of appearance of the lesion. On the right-hand side, you see a very cellular lesion which mimics a myoepithelioma. It's a very monomorphic with plasmacytoid type of cells. The differential in these cases would be myoepithelioma, sometimes can be adenoid cystic, as we said, or if the atypia is significant, carcinomex, pleomorphic adenoma. Adenoid cystic tumor, well, as you can see, this looks very similar to one of the images which I've shown you. This is globular metachromatic material, which is basal membrane-like material, but the cells surrounding these globules are more spindly. They have a slightly more abundant cytoplasm. They're not as dark and basaloid-like, even though they can look pretty basaloid. And the matrix is acellular as opposed to the pleomorphic adenoma matrix. There is some degree of variable nuclear atypia as well in adenoid cystic carcinoma. This is the histology counterpart, and as you can see, the appearance is very typical. That is these gland-like spaces with matrix surrounding these aggregates of basaloid cells, but in the background you see also the more typical myoepithelial type of cells dispersed in the stroma. So these are the sort of lesions which raise for sure the possibility of this being a malignant lesion. And then we have the basal cell adenoma / adenocarcinoma, because very often we are unable on cytology to separate. We tend to say this is in keeping with the basal cell neoplasm. And you have solid tubulotrabecular membranous patterns. There is peripheral palisading, and the material matrix is acellular, and as I showed you before, it can have typical features which resemble adenoid cystic. So at this point, we'll run the questionnaire on what you think, the poll, and I would like to hear what you think about this case number 1. So you can click on it, and it's purely anonymous. I don't know anything and anyone, and we'll just get an idea what it might be. These are the categories from the Milan classification, of course. You might not be particularly used to it, but more or less they represent the main categories which we've been using in the past. So please feel free to go through. We don't have that many answers yet. Okay, now they're coming in. And I can say, well, those who haven't voted yet, please go along and try to vote, because that would be interesting. Okay. We got around 21 answers, which is about 54% of audience. So the last 5 seconds, and then I close it. Nobody's going to judge you. Okay, so we can close this. We had 23 answers, and they are pretty wildly spread out. 17% thought it was benign, 26% was a TP of uncertain significance, 26% neoplastic or sump, 22% suspicion for malignant, and 9% thought it was malignant. So the spectrum is huge, which confirms that this was an intriguing case. So this is the sort of picture at high magnification, pretty monomorphic. This is an example of a basaloid adenoma of membranous type, and you can see on the Papa Nicolau, sometimes if you're lucky enough with the FNA, you can actually see very well this basal-like membrane with these basaloid cells which are palisading on one side of it. This is a very good diagram which is showing you the main difference between basal cell adenoma, basal cell adenocarcinoma, pleomorphic adenoma, adenoid cystic carcinoma. I won't go through in detail, but I just want you to check that the main thing of the main differences between adenoid cystic carcinoma and basal cell neoplasms is the fact that there are variable numbers of myoepithelial cells in the adenoid cystic carcinoma because the metachromatic material, the globular metachromatic material, can be very, very similar in both. And instead, they're just basaloid cells, one slightly more hyperchromatic, and most of this case had them, and slightly larger pale cells as well. So this was a benign basal cell adenoma on histology with focal dysplastic changes. We had labeled it as sump, but it's one of those intermediate categories. And we actually, in the discussion, did highlight that we didn't think it was an adenoid cystic carcinoma because of the monomorphism and the pure type of basaloid cells making up the lesion, but that adenoid cystic couldn't be totally excluded. So the patient was operated, and sorry, this is the next case. Was operated, and somebody's moving. It's not me. And the lesion was actually benign. The nodes were all intact, and the patient went on and happily lived the rest of her life. So this wasn't a malignancy, and it was entirely accepted to suggest this was a neoplasm because of the monomorphism. And in the differential, you might want to discuss whether it's a basaloid lesion, basal cell adenoma, basal cell tumor, and ruling out adenoid cystic or making that less likely. So case 2 will go faster now. It's a 73-year-old male, 9 millimeters hyperechoic focus, left parotid, but also smaller foci in both glands and query abnormal nodes. The patient had a previous squamous cell carcinoma of the larynx treated with chemoradiotherapy 10 years previously, and this is an FNA of the parotid mass. And you can see that the background is dirty. It was a cystic type of findings. There were some pretty normal bland cells which had an acinar appearance over here, or at least let's say they were arranged in sheets, but the background was pretty dirty. There were polymorphs, there were lymphocytes as well, and then there were poorly preserved cells or ghost cells, which in some area looked slightly more squamoid, but we couldn't see atypical squamous cells. We could see squamous cells, but this orangophilic material, we were never sure whether it was just debris from the cystic background, and they were mixed with histiocytes, macrophages, and reactive cells on the whole. So this sample, in summary, contains abundant debris in an inflamed cystic background with macrophages, few neutrophils, outlines of possibly necrotic cells or poorly preserved cells, many with a polygonal outline, only 2 or 3 observed groups of intact epithelial cells with enlarged atypical nuclei, and that can be very subjective because this is poorly preserved material. No lymph node or normal salivary gland material is seen. So we can run the poll now, and in view of the clinical information, in view of this cystic background with cells which are not that easily identifiable, I would be interested to know what your impression is on. I understand that you haven't been shown that many images, of course, but this is not a test. It's just for the sake of discussion, actually. Okay, we have 25 answers. So it's about, more than half. So we can close it here. Just to let you know, about 37%, the largest category is atypical of uncertain significance, then followed by suspicious for malignancy, and then benign, 15%, and just very few of you thought it was malignant, and very few thought it was simply neoplastic with no other attribute. So this is the issue with cystic lesions. You know, when you FNA a lesion in the head and neck, sometimes you don't really know what you're dealing with from the start. And that is why communication with the clinician is absolutely essential and paramount. I'll never stop saying that to my residents. And it is, of course, pretty useful. It can even be thyroid in some cases. In children, we used to do quite a few FNAs of lymph nodes, enlarged lymph nodes in the pediatric population, especially if the lymph node had been there for a while. It's very good in order to send it then also to microbiology. But the point is that it's very rarely malignant, and most commonly can be, for example, cystic lesions, which are benign and reactive. The rule of the neck is 80% of non-thyroid neck are neoplastic, 80% are malignant, 80% are malignant masses in adult, and 80% of primaries are located above the clavicle. And the most common diagnosis in the elderly is, of course, metastatic squamous cell carcinoma. So it's almost impossible not to be slightly biased by this. And we have to remember that both salivary lesions, lymph nodes, soft tissues, branchial cleft cyst, which is always to be kept in mind in young adults, as well as mucinous cysts, can mimic the clinical appearance. So you don't really know exactly where you are, so you have to check. So you can have mucinous cysts. In that case, you have a background which suggests some mucoid material with mucophages or signet ring cells if it's mucin secreting cells, if there are, it's an epithelial lesion. It can be low-grade MUCO-EPIDERMOID carcinoma, in which it might be difficult to find the intermediates or squamous cells. It can be warting tumor, which is a lot more common than we think, or pleomorphic adenoma with mucinous metaplasia. So the mucinous finding of mucinous lesion is not necessarily an entity by itself, okay? Instead, for high-grade carcinoma, when their tip is so obvious, then the spectrum is, and the differentials between salivary duct carcinoma, high-grade muco-epidermoid carcinoma, or carcinoma ex pleomorphic adenoma. But it can be also metastatic, of course. We have to check always the clinical history. It's essential. Stick to reproducible morphological criteria. Do not try to oversee changes. And I have to admit, in this case, we did try to oversee changes by interpreting a lot from the clinical information. And describe the findings. Do not try to reach a conclusion if the material is non-diagnostic. Don't push it. There are limitations. So this actually turned out on histology, and we didn't think about it, as a warting tumor with cystic changes and squamous metaplasia as well. So when you find these big cystic changes, not necessarily with poorly preserved material, ghost cells, not necessarily that is necrosis. So you have to think about all the differentials that we listed beforehand. The case number 3, it's a 78-year-old male with a right parotid mass with abnormal nodes. And we did, the clinicians did FNA directed. And this is the MGG, which you can see as a digital image. And as you can see, there are lymphocytes in the back, but also some larger nuclei, which we couldn't really interpret. And there is a dirty background with chronic inflammation and some cystic debris as well. So summarizing, it was a polymorphic mature lymphocytes with abundant neutrophils, some debris, you probably we are wrong in calling it necrosis, but it's more debris, and metachromatic proteinaceous fluid. So we thought about subacute inflammatory changes, possibly affecting the salivary gland, and because we interpret the larger nuclei possibly as being of acinar origin, and to correlate the findings with the microbiology. So the clinicians thought they had aspirated a lymph node. Why should you aspirate a lymph node? Well, in the general practice, it makes a lot of sense. In tertiary referral centers, the hematopathologists are deadly against it because they want to see the entire lymph node. But actually, in a general practice setting and district general hospital type of setting, the great majority of lymph nodes enlargement are actually benign. So it provides valuable diagnostic information at very low cost. It's simple and safe. If it's palpable, you don't need ultrasound. You just stick a needle without aspiration. You don't need to connect it to the syringe. You use the French method of going up and down with a 25 gauge needle, and then you push out the material with air through a syringe, and there you have it. You already have a nicely diagnostic lesion. And the smaller the needle, the less blood you're going to get. And so, and also the other thing is, one pass you smear, all the rest of the material, you put it in saline or RPMI, because we can do flow cytometry and immunophenotyping, which in 90% of aspirates can accurately diagnose lymphoproliferative disorders. And in any case, it selects patient for the surgical removal of the lymph node. So, and it allows microbiological examination. So it's a comprehensive way of dealing with unknown lymph node enlargements. These are some of the indications. We already discussed them, so I won't spend time. We always like to use both Papa Nicolau and MGG, and additional material can be washed in saline for immunohistochemistry, PBS, or RPMI for flow cytometry. Gene rearrangement is rarely done on FNA of the lymph node. The questions you have to ask yourself as a cytopathologist are basically 5. Is it a polymorphic or monomorphic population? Is it, if it is polymorphic, is there a dominant population? And that relates predominantly to the presence of centroblasts, the intermediate type of lymphoid cells, which can classify follicular cell lymphomas. Do the population record normal lymphocytes from the lymph node, or are they obviously atypical? How many non-lymphoid cells are there? Plasma cells, histiocytes. Obviously, there are lesions which are polymorphic from the point of view of the lymphoid infiltration, but then have diagnostic cells in them. And is there non-lymphoid atypical population? And just to highlight the difference between flow cytometry and immunohistochemistry, you need more material, or better, more slides for immunohistochemistry, which is why we'd rather have liquid-based material, so we can do cytospins or a cell block. Nowadays, we tend actually to do a cell block because immunohistochemistry is more reproducible. But flow cytometry is superior to none, actually, in order to detect the kappa lambda ratio, so whether a lesion is monoclonal or not, and to see whether there's a small monoclonal population, which is much more subjective and difficult to identify in immunocytochemistry. This is another example, just to show you what you can do from a good smear. This was a submental node in a young adult who had bone marrow transplant. So he was possibly immunosuppressed for a previous lymphoproliferative disease. And he had this enlargement, and you can see a carpet of small lymphocytes with some histiocytes, which are these, easily recognizable. But then there were some large cells with 1, 2, or 3 nuclei, which resemble Reed-Sternberg cells or Hodgkin cells, prominent nucleolus. And on MGG, which is a very good stain to highlight eosinophils, we could actually detect an increased number of eosinophils. Together with the same, this is a lovely example of Reed-Sternberg cell, prominent acidophilic nucleolus, large nucleus, mirror-shaped nuclei, and the same nuclei can be in single cells. So these are Hodgkin and these are Reed-Sternberg cells. Together with the eosinophils and the polymorphic lymphoid population, it was easy to suggest that this could have been Hodgkin's disease. And these are the immunocytochemistry on the cytospin. As you can see, when the material is well preserved, the findings are very nice and very clear. This is the CD30, which is positive, CD20 also highlighting the same cells, and a small population of reactive T cells as well. So is there a role in doing flow cytometry also in masses from the parotid submandibular nodules? Yes, because there are quite a few lymphocyte-rich lesions, such as myopathy ciliodenitis. Warting can be pretty rich in lymphocytes, especially the solid variant. And then there are lots of lymph nodes which can be enlarged in the parotid site. So to confirm with flow cytometry the population is polymorphic and the kappa lambda ratio is maintained, it can be very, very useful. So the pitfalls in the interpretation of lymph nodes is that we are not very good in separating low-grade lymphomas from reactive hyperplasias. We are mediocre in subtyping lymphomas unless we constantly use flow cytometry and immunophenotyping. And then if there's partial involvement of the lymph node, of course, it depends where the needle has gone. So you might disagree with me, but the best solution is conventional cytology performed by or with a skilled cytology. If you're lucky enough to have a cytopathologist in your unit with immediate assessment of material, you can decide how to process it straight away. Second best is very good communication and feedback with the skilled, between the skilled clinician and the cytopathologist. And third best, but inevitable in this era of centralization, is liquid-based cytology. You just aspirate and put everything in a liquid vial, possibly splitting between a liquid vial with a fixative and saline or RPMI, depending on how far you are from the lab. But I would encourage everyone to communicate with the cytopathologist, and we are ready to answer all your queries so as to optimize the material. We can also do molecular testing, and I'm spending just a few words on it because in salivary lesions it's less popular than in thyroid. In thyroid we have thorough experience of molecular testing because we know that in some lesion, for example, papillary carcinoma, BRAF mutation can be readily identified. Now there is a very good antibody for it as well, but we had the possibility of getting next generation sequencing, and the quality of the DNA from FNA is second to none. It's actually better than in histology, because in histology you have to process, paraffin embed, therefore there are temperature shocks which affect the quality and the amount of DNA, while instead in cytology it's fresh material which can be immediately analyzed. And so both in the thyroid and with little experience also in the salivary gland, the quality is excellent. And not only, we can also scrape the slide and obtain DNA from old slides as well. And even though the yield, the quantity of the DNA is less, but the quality is exactly the same. So we checked for BRAF mutation both on FNA and old slides which have been scraped. And when there was a mutation, it was identified with both methods. So this is going to be pretty much the future. Actually, it's the present. And I'd just like to inform you that at NRL we'll have a next generation sequence platform ready and available in the next few months. So the histology in this case, and I won't run the poll, was a lymph node with the follicular pattern, and the histology suggested follicular lymphoma grade 1-2. So we were caught on this case, and it just shows you how the sampling and the amount of material has to be representative of the lesion. Case number 4, which is the last of our cases, but in future we'll add many more on that website where these cases are already digitally scanned. There's a 35-year-old male with previous parotid tumor, FNA of the left supraclavicular node, and we have both the MGG and the Papa Nicolau. It's an extremely cellular lesion, as you can see, so immediately it arises suspicion, and the cells are either pretty dispersed with very fragile cytoplasm, but then there were groups with a denser cytoplasm and very aggregated, and there was also some mucoid filaments of tissue in the background, as well as cells with sort of denser and in some areas more vacuolated cytoplasm, such as these cells. And basically, this is the high power view, which clearly identifies two types of cells, one which has the cytoplasm containing material which is slightly metachromatic, and with the peripheral nucleus, which is pushed like like signet ring, and then more solid, well-defined cytoplasm, relatively monomorphic cells. So let's open the poll. What do you think about this lesion, please? This is case number 4. Please click on it so we get everyone's opinion. You're much quicker in making up your mind on this case. Yeah, I think the vast majority of you got it right. Some are more cautious. So last 5 seconds. Okay, so basically, so now we close the poll, and the vast majority thought it was malignant, and I guess you have a definite idea what it might be. The second largest category was suspicious for malignancy, which is entirely acceptable. You know that the risk of malignancy is so high that surgery is mandatory in this case. There was a good proportion, however, who thought this might be neoplastic or some, undetermined malignant potential. So if we've seen mucoid background, then clear cells with fragile cytoplasm, bland nuclear morphology, arranged in acinar sheets or singly dispersed, often as bare nuclei. You saw many bare nuclei in the background. But then there was also a second population with denser cytoplasm arranged in sheets. No evidence of necrosis, and this was a low-grade MUCO-EPIDERMOID carcinoma. So those of you who thought it was malignant or suspicious malignant, I would have encouraged to discuss that the differential would have been a low grade. But remember that actually it's the most common cause of false negative cytologic diagnosis, the low grade. The high grade, no. But the low grade, because it can be very cystic, and aspirates might yield just cyst content, as we've seen in some of the cases. When it's cystic, the diagnostic material can be so little that you actually don't reach a conclusion. But the mucin-containing cells were obviously there. They were not histocytes or mucophages. They were actually signet ring cells. So they can be extremely challenging, and I compliment you because the vast majority has got the right answer. This is another case with the classic signet ring type of cells and surrounded by intermediate type of cells with this tigroid background, okay? And this is the histology. It can be cystic, so if the needle goes in here, cyst can be much bigger as well. Then you have this debris with not that many cells, or so few that you find it difficult to make up your mind. And this is the actual histology of this case, showing both the squamous cells as well the mucin-secreting cells. So this was the last slide. Thank you very much for your attention. I see that quite a few managed to get right to the end. I would encourage you to stay, because now you're going to run a survey so that we get some feedback from you on how to organize the next meetings, whether you like this format of cases, which you can also then screen because they're digitally scanned and available, whether you want more of a slide seminar type of, but remember that it won't be only the topics won't be only cytology or surgical pathology, but will be also clinical pathology. And in this day and era of COVID, of course, I'm pretty sure there will be a thorough COVID discussion as well. So I would thank you very much. Please get in touch with us. I know there have been some possibly questions, please come back to us if you have any comment, query, etc. My address at NRL is rdina@nrl.ae, and thank you very much for your attention.